all for joining us today for a new session of the Campbell webinar series. The GUSSI webinar series is a platform for the GUSSI networkers to share experience and expertise in evidence synthesis and to learn about potential collaboration. My name is Zahra Said. I am the coordinator of the GUSSI Secretariat, and I will be leading the session. So before we begin, and if you are using the GoToWebinar for the first time, as you might have noticed, you are automatically muted. So if you would like to submit any comment or ask any question, use the tab on the right to type in your question or comment. And if you would like to comment or address our presenter directly, you can use your hand button and we can unmute you. So today's session is about an introduction to study quality assessment in social science reviews. And our presenter who's going to be with us today is Jeff Valentine. Jeff Valentine is a professor and a coordinator of the Educational Psychology and Evaluation Program at the University of Louisville, U.S.A. Dr. is a co-author of the Handbook Research Synthesis Analysis, and he is the co-chair of the training group, the Campbell collaboration, and a statistical editor for Developmental Psychosocial Learning Problems group in the collaboration. Thank you, Jeff, for being with us today and joining us and for giving this presentation.
Well, thank you, and welcome everybody. Give me just a moment while I take control of this. And so with luck, I think everybody can see the slides here. And Zara, thank you for the introduction, and it's a pleasure to be here with the GUSSI network. I have, just as a bit of housekeeping, I have maybe about 30 minutes of comments for you today, or this evening, this afternoon, this morning, wherever you are, and whenever you're listening to the recording. If you're listening to a recording, thank you, and thank you for joining, and welcome. The 30 minutes of comments will give us, or 30 minutes of comments from me will give us time for questions from you. So as you are listening, make a note of anything that's not clear, or if you'd like to follow up on a point, I'll be, of course, happy to do that. So Zara gave me an introduction. This is pretty much who I am. I'm a professor at a university in the United States, University of Louisville, which is in Kentucky in the United States. I, many of you know, have Campbell collaboration involvement and also involvement with the Cochrane collaboration. And I'm one of the co-editors of the Handbook of Research Synthesis and Meta-Analysis. So it makes me happy to be able to talk about things related to research synthesis and systematic reviewing. The problem that we're here to talk about today is that with the kinds of reviews that are done within GUSSI and the kinds of reviews that I'm interested in have two particular features which are interesting and create challenges for us. And one of these is that we typically do not have a large number of randomized experiments with which to work, even though we're often interested in the effects of interventions. There will be generally few randomized experiments. And then a related problem, one of the reasons there are few randomized experiments, is that the systems that we're interested in tend to be complex. So we're interested often in complex interventions that exist in a web of other complex systems. And so it gets really difficult to untangle questions about what works under what conditions and for whom in these kinds of systems, much more so difficult than in less complex reviews. So, but the issue is that essentially everybody knows that study quality can influence a study's results. And then, so that means, well, if we're interested in doing reviews in a situation that does not involve a large number of randomized experiments and involves complex systems, how should we address study quality in these situations? And how do we do that while ensuring that the methods that we use are transparent and reproducible, which are two very key principles in evidence synthesis. So I'll say that I'm not going to be able to fully answer this question today. This is an introduction, and what I hope to do is convince you that maybe the first thing that you would try to do, which is to use a study quality tool the way that it was designed, is not going to be a helpful approach. And the reason for this is, I'll get into, there are several reasons, but the underlying issue is that study quality assessment is much more difficult than it seems on the surface. So if you've ever had a class where you've done research, which I just talked over, and you missed this slide, which I put together the nice little images, and then we were on this slide, so not much. So Sabina, thank you for bringing that up. And Zara, thank you for interrupting. Okay, so I think the point I was making was that the study quality assessment is much more difficult than it seems. So if you've ever been in a class, a research methods kind of class, probably the rules seemed like, I bet it seemed like there were a lot of different things to worry about, but at the same time, the rules were pretty cut and dried. So the rules were clear, even if there were a whole bunch of them, and sometimes they were difficult to understand. I think that study quality assessment is actually much more difficult even than you would imagine after taking a research methods class, and I'll have a lot more to say on that. So in addition to convincing you about those 2 points, that this is hard and that you can't use study quality scales the way that they're intended, I have some preliminary advice built into the end that we can talk about. So let's start with defining study quality, since that's what we're here to do today. And I like the idea that study quality relates to the extent to which the design of a study and then the implementation of that design support the types of inferences that the systematic reviewers want to make. So in other words, study quality is not independent of how the information will be used. In like British English, you'll sometimes hear the term horses for courses, or you might be familiar with the phrase fit for purpose. So if we are interested in doing a study where we're trying to tease out causal relationships, we need a different kind of study to support inferences there than if we're just trying to figure out associations. So whether quality of life and depressive symptomology are correlated with one another, are they associated? We need a different kind of study for that. So there's not a one-size-fits-all thing, and it really the crux of the issue here is the kinds of inferences that we want to make. And you'll see that there are 2 key challenges here for assessing study quality. And so the first one is identifying the relevant study quality indicators for a particular research question. And by relevant, I mean that it biases the effect size. This is really challenging because you'll see that we suspect that there are few study quality indicators which can all or even generally be that we have evidence that there might be bias across a large body of research literature. There are actually few of these. So what we have to do as people doing systematic reviews is we have to figure out what the relevant study quality indicators are for our research question. That turns out to be very difficult to do. And then the other thing that we have to do is measure the study quality indicators that we think are relevant, but do so in a way that avoids arbitrary cutoffs and weighting schemes, and you'll see those in action in a moment, and without relying on the cognitive algebra of the judges. So let me just say that cognitive algebra is a term that Harris Cooper and I borrowed from another branch of psychology, and basically remembering that transparency and reproducibility are key principles in evidence synthesis. Cognitive algebra refers to the things that go on inside a reviewer's head that are not transparent and are not reproducible. So each of us might be presented with a judgment: is this an important problem or not, for example, and we can come up with an answer, but that answer is unlikely to be reproducible, and it's definitely not transparent. So we have to do it in a transparent and reproducible way. I want to start illustrating the problem with what's now a classic study, and I apologize if you've heard me or others like me talk about this one before, but it really is an interesting study because it shows very clearly what the problem with study quality scale, what the problems with study quality scales are. So this was a bit of work that started with an existing meta-analysis on the effects of different types of heparin for post-operative deep vein thrombosis, DVT. So basically the developing blood clots after receiving an operation. And this is a really important problem. It kills lots of people every year. It's one of the primary risks of surgery is developing a blood clot that can kill someone after surgery. So it's a really important problem. The issue here was there's something called standard heparin, and in the meta-analysis it was being compared to something called low molecular weight heparin, but I'm going to refer to these as the new versus the old version. So the new version was the low molecular weight heparin, and the old version was standard heparin. So Peter Juni and his colleagues found 25 study quality scales, and most of those, so 24 out of 25, were published in peer-reviewed medical journals. So presumably these were good study quality scales. And then what they did is they conducted 25 separate meta-analyses, one meta-analysis for each study quality scale. Because this is such an important point, I've actually illustrated this twice. So you can see that Peter Juni and his colleagues started with these 25 different study quality scales, and then what they would do is they would choose one. And then they applied that study quality scale to each study in that meta-analysis comparing standard versus low molecular weight heparin. And they created what they called good study and bad study categories based on the study quality scale. So if the study quality scale said it was a good study, it went to the good study category. If they said this is not a trustworthy study, then it goes into the bad study category. And then they redid that original meta-analysis. And what they were interested in is what did the good study say and what did the bad study say? So they did that for one study quality scale, and then they did it all over again. And did it a total of 25 times. So what did they conclude? And this is where it gets interesting. So about half the time, the low quality studies and the high quality studies agreed about the relative effectiveness of the two different versions of heparin. For about a quarter of the studies, the high quality studies said the new version of the drug was better, and the low quality studies said the new version of the drug was not better. But then for the other quarter of studies, the conclusion was opposite. So the high quality study said that the new version of the drug was not better, and the low quality study said that the new version was better. So what's happening here is that the conclusion about the effects of this drug, which is it's a really important research question, has a potential impact on probably hundreds of thousands of lives every year. The conclusion that one would draw depends on the study quality scale that was used to assess the evidence base. So it would be like this. It would be like if I'm getting ready for surgery and my surgeon sees a meta-analysis that's relevant to the surgery that she's about to do, and she says, oh, but they didn't take study quality into account. I'm going to go get my favorite study quality scale, and I'm going to redo the meta-analysis, and I'm going to choose the action that the high quality studies say that I should do. Well, that would mean that my treatment will depend on which study quality scale my surgeon chose. And that's not the way this is supposed to work, right? We think we're doing something that's less idiosyncratic, but in fact, it seems like this is a highly idiosyncratic activity. So one of the things that Harris Cooper and I did was we dug into why that happened. And I think you can characterize 3 problems that you're seeing here on the screen as problems with the scales themselves. So the first thing that I noticed when I collected those 25 scales is that they varied widely in the number of items that were on the scale. So the range was 3 to 34. Those are very different scales. They're covering very different things. But so that's an indication that maybe there's not a lot of agreement in terms of what's going on here. Another issue is that there's no empirical evidence for weighting schemes. And that would include equal weighting, by the way. One example is that there was a scale by Brown and colleagues, 1991, that gave 14% of the points to randomization and 5% of its points to masking outcome assessors. Another scale by Beckerman and colleagues had exactly the same number of items as the Brown scale did, but it gave 12% of its points to masking outcome assessors and 4% of its points to randomization. So basically, those ratios were flipped. Brown said that randomization is 3 times more important than masking. Beckerman said that masking is 3 times more important than randomization. This situation happens because there's no empirical basis for those weighting schemes. And then the last thing that you'll see is that these scales almost always rely on a single score to represent study quality. So if you're used to the internal and external validity kind of framework from the Campbell tradition, you can imagine that one study might have high internal validity and have low external validity, and that might get an 80. And then you could have another study that has low internal validity and high external validity, and that also gets an 80. Those are 2 very different studies, and they're getting the same number that get to represent its quality. So that's a real problem. And then if you look at the items themselves, you'll see that they tend to be imprecisely worded and open to interpretation by users. And then they'll invoke arbitrary thresholds. So the example here I have on the right actually does both. So there's something called the Maryland scale that's used in the criminal justice world sometimes. And the question is, do they control for the effects? Does the study control for the effects of attrition? And you get a 1, which is the worst score you can get on the scale, if attrition is greater than 50% and no attempt is made to adjust for the effects of attrition. And then you get a 5 if careful controls are used to adjust for the effects of attrition. So though there is no justification for that 50% threshold, right? There's nobody's going to argue that a study with 49% attrition is better than a study with 50% attrition, and yet it's going to get a different score. And then if you look at how number 5, how the 5 score is worded, careful controls were used. What's careful for me might not be careful for you. And so that really is up to the judgment of the people doing the review. And that means that this is something that's not, it's going to be hard to make transparent, and it's going to be difficult it won't be reproducible probably. So that means that if somebody else tries to replicate the judgments, they're not going to be able to do that. So the problem here is that the important study quality indicators probably vary by research area. And here's an example that attrition is probably less of an issue in universal healthcare, mental health promotion than it is in mental health treatment efforts. So we probably worry a lot more about attrition in the treatment study and less worry about attrition in the health promotion study. Those kinds of issues are the main thing, I think, that give us trouble here. So that means that it's really hard to assemble an evidence base because it's hard to identify things that cut across research questions. I also wanted to just draw your attention to the fact that people do these things that are called meta-epidemiological studies. So they're like meta-analyses of meta-analyses. And Agnes Deschartes and her colleagues actually did a meta-analysis. So it was like a meta-analysis of these meta-analyses of meta-analyses, looking at 56 of these meta-epidemiological studies, so 3,100 meta-analyses included in her work. They looked at a large number of trial characteristics. So I think it was 58 that I have here on the slide. And of those, only 2 were statistically significant with effect size consistently. So that's kind of interesting, isn't it? The problem is that doesn't mean that the other trial characteristics were unimportant. Instead, what I think it means is that their importance varied as a function of the study context. So they're going to be more important in some, less important, maybe even unimportant in other types of research questions. So just to kind of reiterate those lessons, what I think this literature suggests, at least right now in 2020, is that a very large number of low study quality items, when they're looked at across research questions, tend to show either no association or maybe a positive association with effect size. If we conclude that there's no association, again, my guess is that this is because the indicator matters differently in different contexts, not because the indicator doesn't matter. It's just that it's whether it matters depends on context. I will say that the bias that's associated with study quality indicators, if it is positive, tends to be smaller than I expect. So it's, when there's bias, I can convince myself that it's real. It's usually a little harder to convince myself that it's very, very important. So keep that in mind. These tend to be small effects. We don't really know if they add up in a sensible way, but they do tend to be small effects. And then the other thing I'll say is going back to the problem posed by Gessie reviews and the kinds of reviews I'm interested in. I do think that the consensus is that non-randomized experiments tend to be associated with larger effect sizes than randomized experiments. There might be multiple reasons for this, but some of that might be bias. So going back to study quality scales, if those who have had training in economics might resonate with my argument that study quality scales are fake supply. So there are probably thousands of study quality scales that have been published in the medical and social science literature, and essentially none of them have had their validity examined. And yet, people use them, even though we have lots of evidence suggesting we should worry about the validity of those scales. And so just stop and think about this now, and think about, is there any other context in which you would use a scale that you didn't know anything about its validity? So if you're measuring depressive symptomology, or if you're measuring socioeconomic status or something like that, if you know nothing about the validity of the measurement tool that you're using, why would you use it? We normally wouldn't, but for whatever reason, study quality scales have been given a pass. I think the problem is that reviewers know that they need to assess study quality. So demand is high, but it turns out that assessing study quality is really hard to do. And so that means that real supply is low. And then so what happens if demand is high and real supply is low? Fake supply emerges. And that I think that study quality scales are fake supply. They don't really solve the problem that's reflected in the demand. They appear to, but they don't really do that. So then you might ask, okay, well, what should I do instead? And so I want to spend the last about 5 minutes or so talking about the beginnings of a strategy, and I'll point you to a tool that might help. So one thing that I find very helpful is to start this process by articulating what's sometimes called the target trial. The target trial is an idealized version of of a study that investigates an intervention of interest. And the target trial should be ideal, even if the ideal will never be attainable. So for example, if we were trying to figure out whether smoking cigarettes causes cancer, the target trial would involve randomly assigning people to smoke cigarettes or not, even though we can't do that. But what we can do is we can say, okay, well, when studies don't randomly assign, what does that mean? Gosh, it might mean that people decide whether to choose to smoke or not. And maybe the decision about whether to smoke or not is correlated with some other things that might actually be related to our outcome of interest. So that's what the target trial does for you, is to articulate the ideal and then compare how studies fall away from that ideal. And use the target trial characteristics as study quality indicators. It's also the case that the items from study quality scales might be useful in helping you think about what the target trial should look like. So items from study quality scales are okay. You do not want to use study quality scales in the sense that they will add up to a single number or a single judgment about the quality of the study. That's much, much harder to do. So after articulating the target trial, you'll see that we have front end and back end strategies that will help us address study quality. At the front end, what I suggest is that we adopt a few relatively defensible exclusion criteria based on the issues identified when we have articulated the target trial. So for example, we might say that the study must be a randomized experiment, or we might say we'll include non-randomized experiments, but they must statistically adjust for certain important confounders, and we'll say what those confounders are. Or we might just simply say we have to have a comparison condition. But start with a few relatively defensible exclusion criteria that are focused probably on internal validity, so claims about whether an effect is causal. And then at the back end, we'll recommend that we treat other potential sources of bias empirically. So it will be important to describe to readers how studies depart from the target trial. And then if possible, we'll use meta-regression or another analytic technique to help us assess whether study quality indicators actually do co-vary with effect size. And in fact, if the data are plentiful, we might be able to use study quality indicators in the meta-regression to get an effect size estimate that controls for variation in study quality, which will be a nice thing to do. And then with these other sources of potential bias, let me just say that I didn't use the Campbell framework terms here, internal, external validity, and so on, but basically that's what we're going to be doing. We're going to be thinking about construct validity, so the extent to which any particular measure is valid, whether an estimate can be interpreted as a causal effect, internal validity, statistical considerations, so statistical conclusion validity, factors related to generality like sample composition, so external validity. That's what those other types of items will look like. And then I just want to, the penultimate point here is that there are a couple of other considerations that are going to turn out to be important. And I apologize for the wordy slide that's coming next, but there's a lot of information on it. And I just wanted to make sure that folks were able to access it later and digest it on their own time. But the number of high quality studies that the review is expected to uncover is going to turn out to be really important. And then how well the review team understands the context, I think, is important. So if we expect a large number of high quality studies, then I think a good argument can be made for restricting a review to just the high quality studies. So in a sense, that having that large number of expected studies lets us raise the bar for study inclusion in the review. We're almost never in this situation. I just have to say, we're much more likely to be in a situation where if we expect a very small number of high quality studies, then the question is a lot more difficult. And I think that review teams should consider restricting the review to high quality studies in this situation as well. And the reason for this is that if we don't have a very large, if we have a very small number of high quality studies, then we won't be in a good position probably to explore how how effect sizes vary as a function of differential status on the study quality indicators that we've chosen. So just consider that as one possibility. And then here's the really wordy slide about the context. So I do think that how well we understand context matters, and I think it's really hard, even for highly expert people, to understand the context of complex systematic reviews well. It takes a lot of background work, probably a lot of different people involved, and lots of different types of people involved for the team to have a good understanding of the context. One of the great things about randomized experiments is that they give us a mechanism for causal inference, even when we don't know much about the system under study. We're always better off if we know more rather than less about the system, but randomized experiments do allow us to do causal inference when we don't know a lot about the system. So the other point I want to make is that judgments about what studies are defensible, so what characteristic studies have to be defensible, are highly intertwined with our knowledge about the system. So if we don't know a lot about how the system works, we can't make reasonable judgments about whether a study is defensible. And we will actually see this in lots of different areas. So if you think about instrumental variables, we can never really prove that an instrument is a good one. There's tests you can do, but it really involves our judgments about the system. The last people you want making judgments about the quality of those instruments are people who don't know anything about the context under study. So that's kind of an analogous problem here. We really do need to know more about the system to make good judgments about what constitutes a defensible study. So the bottom line point is, if we don't understand the system very well, this could be an argument for prioritizing RCTs, because we know less about how to get defensible estimates from non-randomized experiments. We don't really know much about how people got into their groups. We don't really know what variables ought to be statistically controlled. We don't really know how well that's going to work. We don't know much about potential omitted variables, things like that. And then, so finally, just to make sure that it's not all doom and gloom, I wanted to make sure that you're aware of Robin's Eye, which is a tool that I was sort of tangentially involved in, that is designed to help assess the risk of bias in non-randomized studies. So I've given you a link to a site here, and then there are some other tools here. The bottom image is a screenshot from the link. There's a paper that you can read. You can access the tool itself. There's a template to walk you through a lot of the considerations, and that might be a place to start. The paper will also say more about the benefits and how to articulate a target trial for those interested in doing that. So that's all I have. Thank you for your kind attention, and I should see if there are questions or comments or anything that someone wants to raise.
Thank you, Jeff, for this interesting and informative session. As Jeff said, it's time for questions. If you have any question, please either type in your question in the question tab or press the raise your hand button and we can unmute you. Thank you, Jeff. So I think we have a question from Jose Meneses. I will unmute now.
Yes, thank you so much for the presentation. Could you please say something about the difference between risk of bias and an appraisal of the methodological quality of a study? So there is certain debate around the distinction between the two terms. Thank you.
Yes, thank you for that question. If you mean risk of bias in terms of the Cochrane risk of bias tool, I'll say that I think that the Cochrane risk of bias tool is a fairly limited look at potential bias, and it concentrates its attention on what in the Campbell philosophical tradition we call the internal validity. So it's focused on claims about whether an effect can be interpreted as a causal effect. So my sense is that study quality assessment is broader than that. It's not just limited to bias, although most of the things that we're worried about are going to be related to bias. Bias can occur in things that are not related to internal validity as well. So for example, unreliability of measures will cause what's called an attenuation of the effect size estimate. So it will downwardly bias the effect size estimate. So that's why I prefer kind of a broader conception of study quality than the risk of bias conception that's the way it's has worked out in Cochrane. I hope that helps.
Thank you, Jeff. We have another question from Meenakshi Sharma saying, please elaborate on the inter-rater reliability for different scales and how to check the external validity through scale. By reviewing an RCT, how can we say the population is representative?
Yes, thank you for those two questions. So I'll start with the representative question first. This is another thing that's just a lot harder than people give it credit for. So 20 or 25 years ago, Frederick Mosteller, who is a really famous late 20th century statistician, and Fred and his colleagues did a survey where they were interested in the ways that people use the term representative or representative, and counted something like 15 distinct meanings of that term. So you have to be really careful about what that means when people use it. You just can't trust that just because we're using the same word that we mean the same thing. So what I think you're asking about is how well might this result generalize to the population as a whole? And that is partly a question for replication. So it used to be, if you'd asked me 25 years ago what I thought about this, I would say, well, if you want to know how it's going to work in a different population, because this population is probably not very well defined at all in the study, you need to go out and do this study. You need to go out and do this another time. You do it with the population that you're interested in, and see if it still works. So replication would be the way to go. I do think that now we have somewhat a better suite of tools that might help us at least get an idea of how well the sample represents some defined population. And so basically what I would do is if we're asking how well might this generalize to some other population of interest, we have to be really clear about what the population of interest is that we are interested in generalizing to, so what the characteristics are. And then we can actually kind of compare the characteristics of the sample and the characteristics of the population statistically and try to figure out how close those are. So if you're familiar with propensity score matching, it's not all that different than a propensity score matching approach. In fact, conceptually, they're kind of the same. We're matching a sample to a hypothetical population of interest. But it really starts with us being able to articulate the population of interest very well, and then it relies on the study having reported the sample characteristics that we're interested in, and we won't always know that. So that was kind of the harder one. The easier one, I think, as you said, please elaborate on inter-rater reliability for different scales. And I think what you're asking is, what do we know about inter-rater reliability for different scales? And in general, we know almost nothing. We at best, from looking at a couple hundred different study quality scales in my life, at best we'll know that the authors of the scale convinced themselves that they were able to get what they think is an acceptable level of inter-rater agreement. But there have been very few study quality scales that have had their inter-rater agreement thoroughly assessed by people who didn't develop the scale.
Thank you, Jeff. Do we have any more questions? Meenakshi Sharma would like to ask you a question. I will unmute you now.
Hello?
Yes,
Hello,
we can hear
am
you.
I audible? Yeah, thank you for such an informative talks. I was having many queries which were resolved through this presentation. Sir, I just need to ask, like, if you can elaborate by taking some checklist, explain us points, how to do it. Like the question I asked, whenever I try to do the quality assessment, it is very difficult for me to assess because there is a generally one point to check the external validity, that whether this RCT is applicable or generalizable. The answer gave it very beautifully. The other points is related to the internal validity. So what is the correct way to assess it, a checklist, the points given in the checklist?
Well, thank you for that question, and stay on because I want to make sure that I understand what you're asking. So are you taking the perspective of a user of a checklist, and then you're trying to assess whether the checklist is suitable for your use?
Like we have I'm doing my systematic review now. I have extracted the studies. Now the CASP checklist has been given to me to assess the quality, in which there is one question like, is the findings of the study is generalizable, number one, which takes the external validity, and in the internal validity there are other questions. So how to go about it, like how to say it is representative, it is not mentioned over there. Then there is another question for checking the internal validity, in which says like, were the participants in both the intervention and the control group were similar. So if we are doing the randomization, we suppose it will be similar. But yes, in the demographic tables, there are some tables which shows that there was some difference in the socioeconomic status of the intervention in the control group. So what is the way to correctly go about it?
So, okay, thank you for responding to my follow-up. I think I understand now. I hope that I don't like make anybody feel bad or say something maybe that's too strong, but a question that says, does the study have external validity is a truly terrible question. And for the reasons that I articulated in the talk. So that's a question that is, the answer will not be reproducible. It's not transparent. We don't know how the judge came to that, whatever conclusion they had to come to. We don't really even know what the question means, right? External validity is a big topic, and we don't know if we're talking about generalizability of the sample or of the setting or something else. So it's a truly terrible question. And then the one that you asked about internal validity was your specific example was, are the groups similar? And if you could make an argument that in a randomized experiment we expect them to be, but what happens if there is attrition? So there's loss of the sample from the sample that was randomized to the sample that was analyzed. So people drop out. Well, if people drop out, then you expect that might lead to some differences. And then having to make a judgment about whether those groups are similar, just on that basis is silly. So in general, what I recommend, when people are assessing study quality, they should use indicators. So if we're worried about attrition, we should assess attrition. If we're worried about the validity of the measurements, we should assess the validity of measurements. You don't want to ask these really big questions like, were the measures good, right? Instead, you want to ask very precise, focused questions that get at the thing that is at issue here. So I hear you. I would have a very hard time with that study quality scale as well. And I don't think it's you. I think it's a scale.
Thank you, Jeff. Bincy, Matthew would like to ask a question. Please go ahead. Bincy? In the meantime, we have a comment from Sabina Stein saying, thank you so much for your presentation. I wish to know how justified it is to score the study as overall low if it lacks on only one component, say reflexivity, which is not very common to all fields of study and practice traditions. The research might have sufficiently reported data collection, analysis, and every other detail but one required for assessment.
Yeah, that's a good question. Thank you. So in general, I am skeptical about efforts to roll up the study quality indicator judgments into a single characterization. That said, a lot of really fine people have been involved in efforts that do that. So I don't know. So in Cochrane we do some things, and I'll just say that. The other thing I wanted to say is that no study is perfect. So just remember that. And then the question that you're asking is, if there's only one thing wrong, is it still okay to call it a high quality study or a low risk of bias study? And I think that the answer to that question entirely depends on how important you think that one thing is and how big of an impact it might have had. And so if you think that the one thing is very, very important and that it might have had a big, big impact, then I think you probably shouldn't call it a low risk of bias study. It's probably more likely that the thing that you're interested in is important, but maybe not, sort of totally important or very important, in which case you just have to make a judgment. All of these systems involve reviewer judgment at the end to get to a single number or a single characterization. And there really isn't much way out of that particular box, I'm sorry to say.
Can I ask the question, please? Hello, can I ask the
I can
question?
hear you, yes.
Okay, so actually this question relates to a specific checklist called AMSTAR 2. There's question number 12, which says, if meta-analysis was performed, did the review authors assess the potential impact of risk of bias in individual studies on the results of the meta-analysis or other evidence synthesis? Is it possible for you to tell me what are the indicators we should look out for when thinking about this question?
Well, so let me make sure to point you to the AMSTAR 2 documentation document. I can't think what to call it, but it has an instruction set that elaborates on those things more. But so what AMSTAR is looking at is something like this. So I said that there are front end and back end strategies, things we do at the beginning, things that we do at the end to address study quality. One of the things that we do at the end, if we're lucky, is we do meta regression, and we put study quality indicators in a model, and we try to control for them when we're estimating the effects. That would certainly be, as long as a person applying the AMSTAR checklist thought that you included a reasonable set of indicators in that meta-regression model, that would be one way of doing it. Another way of doing it would be to set the bar really high for study inclusion. So it has to be an RCT that had low attrition and some other characteristics. And that might be another way to do it too. So essentially reduce the amount of variability in study quality indicators across the studies. Does that help?
Yes, thank you. And also, I just wanted to place a request to, if it's possible for the organizers to have sessions on the use of appraisal tool checklists such as AmStar. So that would be very useful. But thanks a lot for your answer. Yeah.
Oh, thank you.
Thank you, Vinci, for this suggestion. It sounds great. We also have a comment from Minakshi saying CASP has a set of 8 critical appraisal tools that are designed to be used when reading research. CASP has appraisal checklists designed for use with systematic reviews, RCTs, cohort studies, case control studies, economic evaluation, diagnostic studies, qualitative studies, and clinical prediction rules.
Yeah, thank you for sending those. I will recommend that if people are interested in those tools, that you ask the same questions that you would ask about any other scale. So ask questions about reliability and validity before you use them.
Our last comment is from Sabina saying, thank you for addressing that, Professor. I have understood correctly. It still requires some subjective assessment.
So Sabina, if we were talking about AmStar, AmStar definitely requires subjective assessment, but there's no way of getting around that completely because there are no right answers about what the exact study quality indicators are for a particular research question. So some degree of subjectivity is always going to be there. What I really hope we can get out of is having that subjectivity entirely be in the heads of the people applying the tool, and instead making as much of that as transparent and reproducible as possible.
Thank you so much, Jeff, for this great presentation. It was definitely interactive. As for the attendees who are with us today, just make sure to follow us for other sessions for the GUEST-C webinar series. And if you have any more questions, please feel free to send us the question and we can direct you to Jeff, or you can contact him directly. Thank you so much.
Thank you, everybody.